Right, thanks very much for the invitation to speak. My last recollection of this hotel was sitting in that room next door in the ARC ERA process where we were tortured for an entire week. So hopefully this is going to be slightly less painful than that. If you take nothing else from my talk today, I think the take-home message would be that we are really perhaps only a few percentage points away in terms of vaccine coverage from having ourselves in the same situation that we're seeing in the US at the moment. And I'm going to take you through, I guess, a bit of a history and then a little bit of current data and then my thoughts on what we should do about it. So basically, we know that our close neighbour Samoa had an outbreak in 2019, which really started through incorrect vaccine preparations a year before that, which resulted in a couple of infant deaths, which of course then impacted on the confidence of the public in the vaccine program itself, and the government to cancel their vaccine program for 10 months despite WHO's recommendations. That, of course, led to the vaccine misinformation, and we know of famous anti-vaccine people who went to Samoa and got in the ear of the Prime Minister. We don't really need to go over that again. And then, of course, in August, the first case was imported from New Zealand. And ultimately, a measles outbreak ensued with 5,700 cases in a population of 200,000, 83 deaths. So we're all well aware of this. And yet, I guess the good news story is that the rapid response of vaccination, where we went from a rate of 31% vaccination to 94% in a matter of 6 months. So by December 2019, the pandemic, or that epidemic, was over, and the vaccination rate was really high again. Vaccines work. We know it. In Australia, of course, and this data is, I guess, somewhat skewed by the fact that it's pre-vaccination, because you can see that the rate is incredibly high back in the 90s, just as we introduced that second MMR dose. And if we look at what's going on since then, we've had cases that have sort of boiled along over the years. But they look really small here in comparison to obviously the rate that we had before that. And of course, we know that most of our cases are imported. We were declared measles free. And by the way, just as a comment, I think that this measles eradication declaration, I think it confuses the public. I think that they therefore think they don't have to worry about it because it's eradicated. And of course, it's a technical term really in the sense, and we of course import most of our cases anyway. And so I think in some ways that's a nice thing for governments to have in a sense, but I think it actually causes confusion. At least that's my opinion. Hospitalisations, obviously, with the introduction of the vaccine, went way down, and we still have cases that come along here. And then hospitalisation and deaths, we've had very, very few deaths from measles since we've had the 2 doses of MMR. Some, but very few. Now, in terms of our current national vaccination programs, we have 2 doses, 12 months and 18 months, and then, of course, adults born after 1966 who have no evidence of previous vaccination. I'm a 64 baby, and I can't recall if I've had measles. I really should go and check. It's sort of bad if I'm going to talk about it, and I don't actually know my own immunisation status. But I think the advice is, if you don't know, go and get vaccinated is a good one. Obviously, we can get early vaccination for infants aged 6 to 11 months if they're travelling to areas of outbreak. And, I'd like to think this goes on. And another thing I want to talk about, I guess, is traveller advice. But ultimately, Australians love going to places where there's lots of measles. So we really do. China, Indonesia, Bali, Thailand, New Zealand. And so we obviously bring those cases back, and then of course we have imports from visitors to our own country. And I'll go over some of the data about the fairly abysmal vaccination rates in our neighbours. Obviously, vaccination is incredibly successful. We all know it's averted 59 million deaths between 2000 and 2024. It's just an enormously stunning number to think about how successful that has been, and yet some people won't take this vaccine. And despite this, though, there is an estimated 95,000 deaths worldwide from measles in 2024, and I think Christine pointed to that data earlier. Now, if we look at our vaccination rate, and it's been pointed out obviously in previous talks, is that, it's good, but it's falling. And so if we look at MMR, you can see that, we have rates generally in the mid-90s, well below the 95% we would like for MMR, and then some now into the 80s. And so that looks pretty good in a statewide basis, but I guess we have to remember that there are pockets, and David, you pointed this out too, where we have really low vaccination rates. And it's my thoughts on this are that we're amazed that we haven't had an outbreak in places like the Noosa hinterland, northern New South Wales, the areas where we know that there are very low rates. And I suspect that lots of these cases maybe aren't even reported in those sorts of communities. And maybe that's what's going on, because it's a lot of those people also like to visit Bali, right? So we have areas where it is absolutely low enough to allow an outbreak to occur at any stage. So while our national rate all looks pretty good, we have work to do clearly in trying to make sure those vaccination rates are up in those areas. This is for 2 doses, 2-year-olds. And we know that on-time vaccination is worsening, and we can see that from 2020, from 70%, for example, for MMR first dose, we're down to 55%. So this is getting worse over time. So we're really on a trajectory as rates fall, as on-time vaccinations fall, to get ourselves in a spot of bother. And if we look at our recent cases, we can see the outbreak in 2019. So as Ian pointed out, we give influenza virus to New Zealand. Well, they gave us measles back in 2019 and Samoa. So that started with Western Australia and traveller from New Zealand, and then we can see there were a number of cases there. And of course, last year, 2025, we had a significant number of cases compared to our historical average, at least in the post-vaccination era. So it's clearly all around. Now, I said to my wife this morning, we're doing pretty well with vaccination, but we know we're going to be in a spot of bother when we start seeing internal transmissions. And then I opened that Bible of science, the Courier Mail, and on page 5 there it said, I think it was page 5, it said, New South Wales, 3 new cases of internal transmission yesterday. So, and you mentioned we're having it here in Victoria as well. So once we see that sort of sustained internal transmission, we've lost the battle, or we're starting to lose the battle. Obviously, all our cases are essentially imported. And if you look at this map, and you can see that a lot of our very close neighbours have large amounts of measles. So you can see Indonesia, we can see Thailand, India, et cetera, et cetera. So obviously, making sure that the rates are as low as possible in those countries is an important consideration, which I'll cover later on. But we really only have to look at the USA to see how easily control is lost. We're only, you get on a knife edge here, and this is cases in the USA, just a colour map here to show where the concentration were, but generally all over. Obviously, a lot of cases in the south and in states that might have voted for a certain person. But ultimately, it was all over. Even California had cases. Now, if we look at what actually happened there in terms of the numbers, we can see they had 2,276 cases. So this is the first time the USA went over 2,000 cases in 40 years. I sort of want to put that into context. That's since 1982, when I finished year 12, 7th form in those days. And they are already to date have 733 cases. So this isn't going away. They're going to have a worse year in 2026, for sure. And you can see that it's already spread around. I mean, you'd think most of it's going to be in the under 5s, but that's only a quarter of the cases. Half the cases are in 5 to 19s, and then 20s, and then unknown ages. And of course, most of them are unvaccinated, so it's no surprise as well. Although there are a few breakthrough infections, and I have some comments on that. But basically, the first 5 weeks of 2026 is 4 times their annual rate. This is not going away. And this is data from the CDC. Obviously, hospitalisations, and I guess one of the lessons we'll go through about New Zealand was, the incredible rate of hospitalisation these cases are in terms of healthcare costs. But basically, 11%, 1 in 10 were hospitalised, but higher rates for under 5s is expected. So no surprise there. Now, we know vaccination's the key, that's why we're here. And I just want to know how our neighbours were doing. And this is 2-year-old vaccination. So this is data from either WHO, in this case, or Health New Zealand. So Health New Zealand's vaccination coverage for MMR for 2-year-olds is 79%. That's woefully low, quite low. Now, I don't understand the WHO data, quite frankly. I don't know if it's me. Maybe I'm a bit thick. But I can't work out how you can get 91% for 2 doses when I break it down by country, where none of them get to 90%. Anyway, I obviously went into biology because I didn't like mathematics. But anyway, Southeast Asia, so Samoa, 60% still. This is WHO data. Fiji, 75, Vanuatu, 53, PNG, 26. Obviously a challenge to collect data in that country. But Indonesia, 82, Thailand, 82. So, you know, it's no surprise we're going to get seeded in because clearly our neighbours have low vaccination rates, and it's obviously would be important for us to make sure that our neighbours are helped in getting those vaccination rates up. Costs, we all know the costs, 12 to 20% require hospitalisation, $47,000 US per case according to that article in Vaccine. $90 million they were estimated it cost to treat the 2025 outbreak to date in the US, which is probably not a vast amount of money in the scheme of things. But I mean the consequences of infection themselves, and you know, we tell people, you know, that how dangerous this disease is. 1 in 1,000 will die, the brain damage, the hearing loss, etc. But this is one that kind of struck me. Unvaccinated children, you know, unvaccinated children become unvaccinated mothers, or at least unvaccinated girls become unvaccinated mothers, and there's no maternal protection. So as this becomes intergenerational, it's going to get worse and worse. Okay, from New Zealand in 2019, now once again, it was declared measles eliminated in 2017, and as I say, once again, I feel this is a confusing thing from a public point of view. In 2019, they had 2,199 cases and a 27% hospitalisation rate. And there's a really interesting study here in Vaccine which looked at cases, 1,400 cases here, or roughly, of people who were vaccine eligible who had got measles. So 70% of them weren't vaccinated. 220, they didn't know. 139 had had 1 dose. And we know that the vaccine conversion rate's about 70%. For 1 dose. And 77 had 2 doses, and it made me wonder about waning vaccination. We know the vaccine's incredibly effective, but it's only, 96 to 97% effective. That's great. But obviously, and the other thing about this study was that vaccinated cases, even though they had breakthrough infections, they still had a lower chance of onward transmission. So I guess the question about is how effective we are long term, and should we think about what we do with older people like myself? For example. So the vaccine we know is not 100% effective. We all know that vaccines prevent disease, not infection, which is a confusion the public really have. But seroconversion rates for 1 dose, 70 to 80%, 94, 95% for 2. In an Italian study, roughly the same, 92. But seropositivity over time, this is a really interesting article in eClinical Medicine where they looked at 10 years after vaccination, 11, so after 23 years after vaccination, your seropositivity is 81%. And so clearly, obviously, it wanes over time. Now, Tony's going to talk to me about memory cells in a minute, I'm sure. But ultimately, do we need to think about perhaps doing something a little different here in terms of the older population? 12% of the USA cases were breakthrough infections. And modelling in the Lancet suggests that in the real world cases they had in the UK were consistent with waning immunity. So that's something for us to think about as a community in terms of what's going on there. So my final slide, and I didn't turn my timer on, so I have no idea how fast I've gone, probably way too fast. Thoughts on improving our response, and I think some of these have been mentioned before. So we need to think about, do we think about boosting adults or at least measuring their immune status? I think the suggestion was that maybe we do a seropositivity study of the population. We're good at doing that in Australia to see what's going on. We obviously need to offer support, more support, improved support for vaccination in our neighbouring countries because they're bringing it into us, particularly the Western Pacific. maybe better delivery strategy. So 20% of people are needle phobic. I know people who are needle phobic. So new technologies like nanoneedles, or the MAPs, which are just basically skin doses that companies like Vaxxis are working on. And in fact, I rang Vaxxis when I knew I was giving this talk and asked them about what they were doing in this area. They have actually done a measles rubella study, phase 1 trial, and they published it. It's in that vaccines paper in 2023. Works very well. And they're going to do a phase 2, 3 in Gambia in sometime this year. But I said, why just measles and rubella and not mumps? And the thing is that mumps is not a problem in Africa where this vaccine is going to be offered. But of course, this would be something that you couldn't then offer in a first world country to subsidise the cost of offering it in a country of lower resources. And so I think it's a missed opportunity in some ways. And I think that was a program under CEPI, but this was designed for those countries. Access, we know we need to lower barriers, to people to get there, just to get to their GP, to get an appointment with their GP, etc. Addressing misinformation, I've given up talking to vaccine skeptics with facts and figures. I talk about now consequences, and that kind of works a little bit better for me, I think. And your mileage may vary, but ultimately they don't believe anything you say in terms of studies anyway. So you just say, okay, well, here's what's going to happen if your child gets this, that, or the next thing. I'm not sure, we'll see how effective it is, but changing one mind is always good. Obviously the COVID effect and reversing those setbacks around mandated vaccines and the things that we did then, and the mistrust of our institutions, which is really caustic and toxic. Traveller vaccination, how effective is that? At the moment we advise travellers to get vaccinated, obviously. Nearly finished. School entry required, we adhere to them, and maybe would screening for early detection be effective, but I think that's more around the seropositivity study. So thank you very much for listening.
Thank you so much for that talk. Is there a quick question from the audience?
Did I go that far?
Paul? In the middle table.
Yep, Paul.
3.
Next to Robert.
Nigel, thank you for that. Having been involved in a lot of pre-nurse training, screening and various others with ambulance services and whatnot, there's no doubt that in a measles elimination area, the benefit of antibodies from pregnant mothers is nothing like it was when we actually had measles circulating and they're not getting boosted. And so a number of those we had to give a third dose to. But the other thing that I noticed your comment about school entry. If you looked at that map of USA that you put up there, there was one state that was white, and that was West Virginia. There was a country singer called John Denver who wrote a song about Almost Heaven, West Virginia, and that was because of the measles coverage, the measles vaccine coverage in West Virginia. They have by far the most restrictive school entry and other processes there, which is managed by having good access. And West Virginia runs at 99% measles coverage, and there's been huge numbers of outbreaks around there that just don't get into that. So maybe that's something that we need to do more about, making sure that people have the right doses at that age.
Yeah, and my only comment about that is, of course, we know the backlash against mandates, so we need to do this in a carefully considered way. But yeah, I didn't know that about West Virginia. Thank you. That's very interesting.
Okay, last question.
Yes, New Zealand.
Thanks, Nigel. I do feel the need to speak on behalf of New Zealand.
I am a Kiwi, you know that.
And I think we have met. My last job before I came to be Chief Health Officer was Clinical Director for the National Immunisation Programme in New Zealand. And I just want to have a message of hope in that the rate that you quoted there in New Zealand has actually gone up. And New Zealand has been targeting very much vaccination coverage, thrown a lot of resources into improving vaccination coverage across the country. As others have said, that's an average. There are pockets of really low coverage and pockets where actually it is 95% now.
And I think you have the issue of the Pacific Samoa population with a very different HLA type that don't respond well to that vaccine.
There are, and there's also then Māori, the Polynesian
Polynesians, yes, which I know that
similarity
the
with
Milligan are working
Samoa
on.
and Māori. So it's really just a point of it can be done
Yes,
with organised efforts and funding.
thank you very much.
Thank you, Nigel.